Hello, so today we'll be discussing another case. So this is what you see under the microscope. So in the low power you see that this is a very busy or an increased cellular smear. It's a peripheral smear, and then the high power also is showing increased number of cells. So you look at the history, and the history that is given is a 45-year male with fatigue and weight loss who presented to the general medicine OPD, and there he was sent for CBC and peripheral smear for evaluation. So this is the history that was given. After seeing an abnormal peripheral smear, we went ahead and took further history, which was the history of splenomegaly. So the patient had a history of splenomegaly. And then what was the negative history? So he did not have any fever or constitutional symptoms or any lymphadenopathy. So this gives a hint towards a specific diagnosis. As we proceed in the further slides, you will understand this. So what is the CBC parameter? So you look at that. RBC is 10 gram per deciliter. There is mild anemia. So WBC count is significantly increased. So what is the normal WBC count? It is 4,000 to 11,000 per microliter. And then the platelet is also slightly increased because the normal platelet count in an adult is 4.5 lakhs. So it's mildly increased. So with that, let's look at the smear again. You see it's a very busy slide. Again, do you think it's an acute leukemia slide? It's very difficult to see in the low power and tell it. So let's see in the high power. Do we think that this is acute leukemia? So try to remember what you studied in the last video of acute leukemia and try to find any resemblance with those cells, right? So let's further learn what all cells should we see here. So this is again a magnified image of that smear. So before that, let's just recollect the normal granulocytes or the leukocytes that are present in the peripheral smear that you see normally. So what is this? This is a neutrophil. This with coarse brick red granules is an eosinophil. This is a basophil, and the characteristic of a basophil is that it has coarse granules which obscure the nuclear outline. So that's very important. Even in the image you can't see the nuclear outline properly, unlike an eosinophil or a neutrophil. Then you already know water blast from the previous video. Then you have the precursors, the granulocyte precursors, which is a myelocyte and a metamyelocyte. Now let's try to find these cells in this smear, right? So coming to a simple one. So what is this cluster? So all of this and this, everything looks like somewhere a neutrophil which comes under stab or segmented, and then you have these clusters. Can you find all of these cells? Can you see, zoom it, can you see any nuclear outline? No, but you can see that the granules are very coarse here and they resemble a basophil. So the normal count of basophil is quite low in a peripheral smear. So you're not supposed to see these many basophils. It comes up to 1% in adults. So you're not supposed to see these many basophils in a smear. Following, so another cell. So what about this cell here? This has a bilobe nuclei, and if you see, the granules are quite different compared to all the other cells. It looks a bit more reddish, right? So this is an eosinophil. Again, you can find one more eosinophil in the smear somewhere, right? This is another eosinophil. And then let's see myelo, metamyelo. So all of this, these cells, these ones that I've marked here are all M plus M, myelocyte and metamyelocyte. You can see normal myelocyte and metamyelocytes are usually supposed to be less than 3% in the peripheral smear. So they're not supposed to be increased more than that. Again, this is a clue. And then from the previous slide, video, you know that this is a blast. So you know that this is high NC ratio, pale basophilic scant amount of cytoplasm and irregular nuclear outline. So now you understood all the cells whatever are present. So now you know this is definitely an abnormal smear. So what is this? Why are there so many cells in the peripheral smear? This is totally abnormal. So this is because there is proliferation of the hematopoietic cells in the marrow, which is pushing all of these cells into the peripheral smear. And you can also see that all of these dots, these are all platelets, right? So this explains why our platelet count was slightly increased. Again, just to revise, you know that these are all basophils. This, they're all eosinophils. These are clusters of myelocyte and metamyelocyte. This is a blast, and all of these ones, these are all stapler segmented, which is the neutrophils. This, see, this is showing a different type of granule, right? So this is an eosinophilic myelocyte, or you can say an eosinophilic precursor. This is again an eosinophil because the granules are different. A basophil again, lots of basophils. Here you can see this is a myelocyte based on the image that we studied here. So now you know all the cells, we have identified everything. We know that all the counts are increased. So what is the diagnosis? It's a diagnostic smear of a chronic myeloid leukemia. So what is the defining mutation in CML? You all know it's BCR ABL1 gene, also translocation 922, infamously known as the Philadelphia chromosome. So, but there are few things that you have to remember here. So, what are the variant hybrid genes? So, P210 is usually seen in CML. P190 is seen in Philadelphia positive ALL, and P230 is seen in cases which have neutrophilic predominance and thrombocytosis. So you know these all four are hybrid genes which are important. So usually in CML you will have BCR-ABL P210 mutation. So how do you report this smear? You write it as neutrophilic leukocytosis. Leukocytosis is increased WBC count. Neutrophilic means granulocytes are more increased, and then you know that presence of myeloid cells like myelocytes and metamyelocytes, the precursors, is known as myeloid left shift, right? So that's how you write neutrophilic leukocytosis with myeloid left shift. Other than that, what do you write? So you'll write neutrophilic leukocytosis with myeloid left shift, and then whenever you have an abnormal peripheral smear, you will give a differential count. So you do a differential count in somewhere around 200 to 300 cells. This is different in CML because the cell count is too high, so you're not supposed to stop at 100. Okay, you're supposed to do a higher cell count. So you do a DC in 200 cells, and then you write the count of myeloblast. How many blasts did you find? Then metamyelocytes, stapler segment, lymphocytes. You have to write basophils here. Okay, this is important. Basophils is supposed to be second, and then stap segment, eosinophils, lymphocytes, and monocytes. Right. So percentage of myeloblast and basophil is quite important in CML. Right, and then you will write whatever else, whatever your RBC parameters and your platelet parameters, and then you will sign out as an impression of CML CP. CP means chronic phase because there are no increased blast. So when do you say that the smear is showing or the patient is a high risk patient? That is when you find blast more than 10% in peripheral smear and basophils more than 20% in peripheral smear. So blast you have to always count, it should be less than 10%, somewhere around, will be around 6 or 7% or maximum 5%. So what do you think? What is this smear? Right, so many. So assuming I will tell you, out of the 100 cells, I found around 26% basophils. So this you can see, right, the basophils are significantly increased in number. So these are features of high risk. They can get transformed into AML or ALL. Then you have an important concept. So this is the reason why I thought that we'll take up CML topic today to teach the NAP or the lab score. So this is not usually done in our institute, but this is an important concept and a lot of institutes religiously do the scoring. So this is neutrophilic alkaline phosphatase score. So why is it done? Is to find out the functional maturity and activity of neutrophils. So how do you grade it? Based on the intensity of granules on the stain, which is naphthalase pi phosphate with fast blue BB salt. You count in how many neutrophils? 100 neutrophils have to be counted, and you have to score each neutrophil, and then you have to give the final score. So if there are no granules, no these reddish granules are there, this is after staining on the peripheral smear, you score it as 0. If they're just faint granules, score it as 1. Moderate amount of granules, 2. If there is strong staining, 3, and then you have very strong staining, which is 4. So now you know that this is how you do neutrophilic alkaline phosphatase score, and I'll tell you why this is important with respect to CML. So just to revise the concept that we studied, so this is 10 cells. You know that you have to count in 100 cells, not in 10 cells, but just for the example's sake, let's calculate the NAP score in this smear. So how many of these are 0? I'll just take, please remember, so this one, right, and this one. Why? Because there are no granules, right? So I will write 0 plus 0, and then you have to find 1. So these are just faint granules, so these can be 1. This is 1 plus 1, and then we need to find 2. So 2 will have just enough granules. We can take it as this, and this as 2. So you have again score of 2. Then 2 of the neutrophils again have 3 score, right? They have strong intensity scoring and very strong intensity. You know these 2 are just highly intense in their staining. So 4. So you calculate the total score, 0 plus 0 plus 2 plus 4 plus 6 plus 8. So the score comes up to 20. Right, assuming this is in 10, so in 100 neutrophils, so the value comes up to 200 in 100 neutrophils. So is this increased or decreased? That we'll find out. So the normal NAP score is 2200 in a smear, in a normal peripheral smear. So in the smear that we calculated, it is coming up to 200. That means the NAP score in that is increased. Okay, so now you know. So what are the causes of increased NAP score and decreased NAP score? And this is why we learn NAP score. So because in CML there is a lot of proliferation of granulocytes, the marrow is just throwing out neutrophils and granulocyte precursors outside, so they're not functionally maturing, right? So because we know that NAP score is for functional maturity, the neutrophils that in CML are not that mature, and hence that is why you have decreased NAP score in CML, in PNH and aplastic anemia. However, increased NAP score is seen in polycythemia vera, myelofibrosis, leukemoid reaction. So this is again neutrophilic leukocytosis due to infection, sepsis, or anything that you see routinely, and stress and trauma. So these are the causes of increased and decreased NAP score. Please remember that this is NAP score, and it's very important to diagnose if a case of neutrophilic leukocytosis is CML or just a leukemoid reaction in a clinical setting. Then just to summarize, so when you see a smear like this, you take the history, you know that this is a patient who has splenomegaly, no lymphadenopathy, then you count differentials, and then you find that there is increased basophils, neutrophilic leukocytosis with myeloid left shift, and then you find that the NAP score is 5. So what do you do? It's decreased, right? So we've learned that in CML, PNH and aplastic anemia, NAP score is decreased. So your NAP score is 5 when you did the NAP scoring and everything. So finally, you give a diagnosis of chronic myeloid leukemia, chronic phase. So I hope this helps. Thank you.
Do check out the acute leukemia video if you have any doubts.